Good morning to all. I am Dr. Arun Kumar, your pediatric faculty. I am going to talk about vector-borne disease, especially dengue fever. So I will cover about regarding clinical features, how to diagnose, pathophysiology and management of dengue fever. Before going there, we should know what is vector-borne disease. Vector-borne disease defined as diseases that are spread by vectors such as mosquitoes, ticks, fleas through their bites. So the Aedes aegypti mosquito causes dengue, chikungunya, yellow fever and Zika fever. Malaria is caused by Anopheles mosquito. Culex mosquito causes West Nile fever and Japanese encephalitis. And tick is spread by Lyme disease, scrub typhus and Rocky Mountain spotted fever. Filariasis caused by mosquito. It could be Anopheles aedes or Aedes mosquito. And plague is transmitted by flea bitten. Cholera is transmitted by sandfly. So coming to dengue virus, it is a single strand RNA virus. Arbovirus family belongs to Flaviviridae family. It has four serotypes: dengue virus 1, 2, 3, 4. Newly dengue virus 5 identified in October 2013. All serotypes are endemic in India. Among these, dengue virus 2 and 3 are frequently associated with severe infections. So infection confers lifelong immunity to that virus of the serotype. Cross protection for only a few months after the infection by one of them, and secondary infection with another serotype lead to severe form of infection. So coming to mosquito, it is dengue virus transmitted through Aedes aegypti or Aedes albopictus mosquito. It breeds almost entirely in the domestic man-made water receptacles. It is a daytime feeder and can fly up to limited distance of 400 meters. Survives best between 16 to 30 degree and relative humidity of 60%. Their eggs withstand desiccation more than 1 year and emerge within 24 hours once comes in contact with the water. There are the same types of mosquitoes that spread Zika, chikungunya and yellow fever. It is also transmitted through vertical infection, blood transfusion and organ transplantation, but these are rare. So this picture depicts the Aedes aegypti mosquito. We can identify by seeing through the alternate black and white strips in their legs. So these are the common place that Aedes aegypti mosquito breeds, which has barrel, mud spots, torn jerrycan, open plastic drum, torn barrel, plastic bowl, plastic drums and ties. So coming to dengue fever, it is also called breakbone fever or saddleback fever. It has an incubation period of 8 to 10 days. It has classically three phases: febrile phase, critical phase and recovery phase. So dengue fever, it is classified into three types. One is probable dengue, second is dengue fever, third is severe dengue. The dengue fever is classified with warning signs and without warning signs. So probable dengue, it is defined as any patients living in the endemic area present with fever along with any of the two symptoms, which is nausea, vomiting, rash, body ache, positive tourniquet test, leukopenia. The classical warning signs are abdominal pain and tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, liver enlargement more than 2 cm and increase in hematocrit and decrease in platelet count. So severe dengue is defined as any severe plasma leakage which lead to shock or respiratory distress or severe bleeding or severe organ involvement such as liver failure, dengue encephalopathy or dengue myocarditis. So this picture depicts the classical three phases of dengue fever. The febrile phase lasts for 2 to 3 days, critical phase lasts for 2 to 3 days, followed by convalescent phase or deprivation phase which lasts for 1 to 5 days. In febrile phase, the patient has high grade fever with myalgia, vomiting, abdominal pain. After that, the patient came to the stage of afebrile period in which the complications will develop, such as dengue shock syndrome, in which the hematocrit is gradually increased due to severe plasma leakage and platelet count fall, and the patient will bleed and develop shock. After in convalescent, in recovery phase, the plasma leakage stops and the fluid resorption occurs. We have to monitor the recovery phase because of increased risk of pulmonary edema. This is the pathophysiology. After the mosquito bite, the dengue virus enters in the human blood. It causes viremia and produces two types of injury: direct cell injury, which leads to endothelial damage, and platelet destruction, which causes severe dengue, or by producing antibodies and causes antigen antibody complexes and produces complement activation. And then it also activates T cell, produce cytokine storm, also produce vasculopathy, coagulopathy, cytopathy, which lead to severe dengue. The first picture depicts the classical rash which is seen in dengue, which it is a diffuse erythematous rash which blanches on pressure. It is also seen in two other conditions such as scarlet fever and toxic shock syndrome. On second picture depicts it is a classical rash seen in convalescent phase. It is a diffuse erythematous rash in which there is a normal skin present in between. It is classically described as islands of white in the sea of red. So not all the patients develop severe infection followed by dengue virus infection. Most of the patients are asymptomatic. Only 30 to 40% will develop symptomatic dengue infection. Among the symptomatic, we classify into mild, moderate, severe dengue. Mild dengue we can treat it as a OPD basis. Moderate dengue is otherwise called dengue with warning signs. We have to admit in the high dependency unit and we have to provide IV fluids. Severe dengue we have to admit the patient in PICU and we have to closely monitor the vital signs. So this is the difference between compensated and decompensated shock. The only difference is in compensated shock the sensorium will be preserved and the BP will be normal and the urine output slightly reduced. In decompensated shock the sensorium is altered and the BP will be low and the patient develop oliguria or anuria. Though this is a test used to identify dengue infection, also called tourniquet test, in which we have to take the blood pressure and inflate the cup, and we have to inflate the cup to the point of midway between systolic and diastolic BP and maintain for 5 minutes and reduce and wait for 5 minutes. If the patient develops petechia in the cubital fossa more than 10 petechia, it's considered as positive in 1 square inch. So high risk factor for development of severe dengue: infants and children, elder people, immunocompromised people, obesity, pregnant women, patients who have hemolytic diseases and peptic ulcer, heart disease and chronic lung disease, and patient on long-term steroid or NSAID treatment. So coming to diagnosis of dengue, there are direct and indirect methods. Direct method is virus isolation, genome detection and antigen detection. Indirect method is the most commonly preferred, which is serology. Most commonly preferred is ELISA based IgM serology. So in the first 3 to 5 days we have to do RT-PCR or NS1 antigen test, which is ELISA based. After 5 days only the antibody will starting to rise. So initially we do IgM ELISA, after that IgG ELISA. So if the patient is developed mild dengue, we can treat it as a OPD basis. So we have to provide rest, paracetamol if the fever is came, and encourage them to take oral fluids, and we have to advise them if there is any warning signs are present. So group B, patient with the dengue with warning sign, we have to admit the patient in HDU and we have to take the CBC, monitor the urine output and assess the vitals, BP such as BP SpO2 every 4th hourly. We have to monitor platelet count, hematocrit, which is vital to assess if there is any complications are developed or not. So in case of if the patient has dengue with warning signs, we have to start IV fluids. Ideal will be NS. Initially we have to start at 5 to 7 ml per kg per hour for 1 to 2 hours, and then we have to assess the urine output, blood pressure and hematocrit and platelet count. If these things are normal and the patient is clinically stable, we can reduce step by step, such as 3 to 5 ml per kg per hour in next 2 to 4 hours, and then we can reduce 1.5 ml per kg per hour. If the patient is worsened, we have to hike the NS fluid up to 10 ml per kg per hour. So if the patient has shock, if the patient develop compensated shock or decompensated shock, first we have to provide oxygen. If it is compensated shock, 10 to 20 ml per kg of NS we should administer for 30 minutes. If it is decompensated shock, we have to administer 20 ml per kg. We have to assess the improvement. If the patient is improved, we have to start the IV fluid of 10 ml per kg per hour over 2 to 4 hours. If there is again improvement, we can gradually reduce and keep it at a maintenance of 3 to 1.5 ml per kg per hour, and then we can discontinue IV fluid after 24 to 48 hours. If it is no improvement, we should again administer 10 to 20 ml per kg second bolus over 30 minutes. If it is improvement, we can reduce to 10 to 20 ml per kg of NS, and then we can gradually reduce and stop. If there is no improvement and the hematocrit rise, we have to maintain the 10 ml per kg per hour, and then we have to monitor the vitals. If the hemoglobin falls, hematocrit falls, and the patient is worsening, we have to suspect any occult bleeding, and then we have to transmit the blood transfusion. If it is whole blood, we have to administer 10 ml per kg. If it is packed PRBC, we have to administer 5 ml per kg. So if there is no improvement, we have to do echo to rule out any myocardial dysfunction. If there is a myocardial dysfunction present, we have to start inotropes. Thank you.